on Nyami Nyami FM and on Diamond FM. I am V Candy Madlamini, and this program is brought to us by UNICEF. It is Health Interventions. I am V Candy, and joining me today for today's discussion is Livison Chipatiso, WASH Head of Department, and he is also with ACL. Hey Livison, good morning and welcome.
Hi Madlamini, how are you?
I am good, thank you. So today we were focusing on improving quality of healthcare by upgrading basic services in healthcare facilities. Livingstone, is that it? Livingstone, okay.
Yes.
Can you give us a brief background of the project supported by the USAID, and what were the key objectives towards the issue of improving quality of healthcare by upgrading basic services in healthcare facilities? What were you looking at?
Madlamini, I'd say this project is an important project because it came with support from USAID as a response to COVID-19. So you'd find that there was a realization by the government and UNICEF that with the coming of COVID-19, we needed to make sure that our healthcare facilities were net centers where people who would go there would then have come back with diseases, infectious diseases from them, but then they should go there and be centers for treatment. So as such, there was an assessment to check the status of the healthcare facilities and using what we call the WASH fit. WASH is water, sanitation, and hygiene. The fit is facility improvement too. So that assessment then gave the gaps in terms of improving those facilities. 100 facilities were chosen, and then USAID came in to assist now to bridge the gaps from the gaps that we have seen through this assessment. So USAID is now assisting us in the rehabilitation and upgrading of 80 of those 100 healthcare facilities.
Oh wow, 80 of the 100.
Yes.
Wonderful. So where were the interventions, Livison? Where were they undertaken in Zimbabwe, and why did you decide to pick those particular places? Yes.
The interventions were in 4 areas. I wanted to say cities, but I think 4 areas. We can say Bedbridge, Bulawayo, Harare, and Mutare. We chose those ones because if you look at Harare and Bulawayo, they are 2 big cities in Zimbabwe with very high populations. So the risk of transmission and the risk, that would mean that there are a lot of people that would need to then go to the healthcare facilities. So those healthcare facilities had to be upgraded. But if you also look at Bedbridge is the main gateway of people from South Africa or to South Africa from the bigger part of SADC. So there is also a high risk of trans-border transmission there. So we needed to make sure that the healthcare facilities in Bedbridge were also rehabilitated, upgraded. Then if you look at Mutare, those people were also coming in from Cyclone Idai, and also now there's also Forbes border posts now to Mozambique and so forth. So we then decided to target those 4 for the upgrading. Thank you.
If you're just tuning in, it is Health Interventions brought to us by UNICEF, and joining us live in studio is Livison Chipati. So you can also come onto our WhatsApp platform. We are live, by the way, on Facebook. If you have any questions or you'd also want to weigh in, you can come onto our platforms. If you may, Livison, outline the key interventions that were undertaken from the support of USAID and the key results achieved from that program.
Oh, okay, Madam. Let me say the key interventions, I can put them in, divide them to say, like I said, WASH. We have water, we have sanitation, we have hygiene. Then I also add environment and also the software. When we talk about the software, we are talking about the mindset, the things that are not tangible, really. So if you look at WASH, with water, I said we start with water. We had water supply to 25 out of the healthcare facilities that I talked about. I said USAID looked at 80 healthcare facilities, but I will dwell on those in Harare and Mutare, 42 that we were doing as ACF. By the way, sorry, it's ACF, not ACF.
Okay,
yes.
Apologies for that.
Yeah, so I'm dwelling on 42. So for the water supply, we had, out of those 42, we had 25 that were given water supply. This means it's either drilling and giving them water supply, but some of them, out of the 42, had their own water. But then we then had to make sure that we take water from the supply within the healthcare facilities for all the 42 healthcare facilities. That's water reticulation to the water points within the facilities. And if you look at that, we also mean that we had to put geysers, solar geysers, water heating units for the waiting mothers shelters mostly.
Oh wow!
Yes, so they were. We put 17 geysers. Some of them we had to repair. Where there were no geysers, we had to put geysers. So if you look at sanitation, we had to repair a staggering 265 latrines for those 42.
They were not functional anymore.
Not functional anymore, and we had those are all sewer latrines. So for the rural healthcare facilities, some of them in Mutari, those were rural healthcare facilities, we also had to put even the septic tanks to start again, to put a new flushing system. And waste management, I said I was going to add waste management. So we also had a problem to say, okay, there is clinical waste, there is also the environment. When the facility has waste, where and how do they then dispose of their waste? That's when we also had to put waste management cages. And washing basins, 388 hand washing basins for those 42 facilities only. So it's a big number across all the facilities. So if I also go now to the software, I said the software is equally important in this project because we need to make sure that we deal with the mindset and that these things that we put are also sustainable. So we had 3 main trainings under the software: the operation and maintenance, which also talks to sustainability.
Okay, so that when you leave, they don't then,
Yes.
Demolish or then are not able to use.
Yes,
the
and get
things.
back to the state where we found them again.
Okay.
So after the project ends, we needed to make sure that there is operation and maintenance there. Then we also have what we call IPC, is infection prevention and control. IPC training for the non-clinical workers. We are talking about if you have ambulance drivers, if you have your they normally call them general hands, but the people who care at the environment at the clinics, and also for the clinical staff, that's our IPC training. And we also have the training in sustainability. Yes, thank you.
Okay, all right. It is Health Interventions right here on Star FM, Diamond FM, and Yami Yami FM, brought to us by UNICEF. And Livison was just telling us of some of the interventions that were undertaken from the support of USAID and the key results that were achieved from the program. We're going to take a musical break and we will be right back. We'll be right back after this. Thank you so much, those who are joining us. We're also live on Facebook. His name is Rocky. This song was originally done by, finish the statement. I like this song. What a song. Rocky and as we party right now, I asked it was originally done by 617, you got it right. 700, you got it right. Tobias Ayuketa. It is a Zim Papers radio broadcast, simulcast. This program, Health Interventions, brought to us by UNICEF. We come your way every Monday and Tuesday around about this time, so you can make a date. And we're talking about improving quality of healthcare by upgrading basic services in healthcare facilities, the projects that they undertook. And before the song, Livingstone was just also letting us in about some of the interventions that were undertaken by the support of USAID and the key results achieved from the program. So you can also watch us. We are live on Facebook. Livingstone, coming back to you. What were the key challenges that you faced in the implementation of the program?
Look, Madamini, I think as a country we are transitioning. We are moving from a situation where people were used to having everything being done to them and for them. So one of the key challenges that we are facing is to do with the people's perceptions. I think we need to continue making sure that people understand that these healthcare facilities are theirs in their communities. So we have issues like in other areas where there is vandalism of those those things that are installed for them. So I think it's
so the community was supposed to benefit, end up vandalizing the things that are supposed to benefit them.
Yes.
That's sad.
So if you have, for example, some copper pipes, then people come to steal those copper pipes and so forth for water reticulation. They are stealing. Then I don't know what they will be doing in that. So I think that's the major challenge that we are facing. So, and the other challenge that we all know that we are facing as a country is that of staff attrition. So if we then come in the trainings that I talked about, the software trainings that I talk about, we come and you train the clinical, especially the clinical staff. We come and train them. Then 3-4 months down the ladder, you have a lot of them have left, maybe to the other centers, or they've left the country. So we have a problem of retraining over and over again, so that we have people who are trained and who have the institutional know-how at that institution. They have that history of the institution. But we also have challenges to do with, I said we assembled 100 facilities. So we also have challenges to do with other facilities that were not in the first assemble. I should say this was a pilot project.
Okay.
So some that were not in this, they're also calling us and they need this facility, and there is the need. There is a need, I should say. But some of them, we have visited them. There is a need, I should say. And also time of implementation, we're in a COVID era, so this was really an emergency. But for those issues that deal with software, like I said, to do with operation and maintenance, to do with the mindset, they really need longer time for that to get into people's mind. Thank you.
And it does make sense, Livingstone. Could you tell us about how WASH services improved in Harare, the parts that you were in, as well as in Manicaland?
So if you go to the facilities that we worked on, the 42 facilities that we worked on in Harare and Manicaland, 6 in Manicaland and 36 in Harare. If you go to all of them now they have adequate water supply. So we put what we call the dual pumping system using solar or electricity. So even if there is load shedding, they should be able to pump using solar to have adequate water at the facility. Without adequate water, it's very difficult at the facility. So there is adequate water there. The mothers are getting warm water in the wards.
Oh, that's really good, eh?
Yes. And they are using the flush toilets, and the toilets are adequate for the people that are there. There is a way that we calculate the adequacy of the toilets. So all the latrines that were not working, they are now working. Waste management is now okay. They are sorting the waste, clinical waste, and also taking to the cages for further processing. But we also have incorporated the healthcare committees, which WASH equivalent to the schools. I think people are familiar with the SDCs at schools. So the healthcare committees are really community committees. It's made up of the community people from that the surrounding of the healthcare facility. So we have those people now. They are now there. They are managing the affairs of their clinic, particularly the environment of the clinic. So there is the environment is now clean. So I can say that in a nutshell.
Okay. So you also had healthcare facility staff and also non-clinical staff. And we would want to know, Levison, how do they benefit from WASH or infection prevention and control? That's IPC training. How do they benefit from that?
Okay. What we did is we divided the support about infection prevention and control into two, having realized that before we were, or can I say, projects were dealing mostly with the clinical staff to train clinical staff on infection prevention and control, leaving out the non-clinical staff. So what we did here, we had a separate training for the non-clinical staff. Why? Because these people, when we have a disease outbreak, infectious disease outbreak, they are the people who are also dealing with the patients. They are the people who are handling the patients. If you get, for example, people who are the ambulance drivers and so forth, and the people who work with the ambulance, are the people who are handling the patients. Then if you come to the clinic, these people are the people who are supposed to be cleaning the environment for the patients. So they are also at risk of contracting those diseases and spreading them. So we had a training for the non-clinical staff on IPC. Then we also had a separate curricula which we call mentoring of the clinical staff. Now we're using our colleagues from within the project who are medical practitioners to then mentor the clinical staff. So the trainings is one of the things. That's why we divided into two. Then we went on further to say, okay, the trainings alone without then giving them the resources for IPC would not make sense. Then the project also came in with a lot of IPC material for them to be using now to apply the knowledge practically. Thank you.
And we're talking about sustainability. And could you also tell us, Levison, about how WASH services can be sustained?
Yeah, Amalamini, I think this question is linked to the question that you asked me on challenges. When I to complement the efforts of the government of Zimbabwe, and we need a wholesome response to the challenges that we are getting. For example, I talked about the issue of the mindset of the people, that people need to then know that is their facility. I think that's the biggest thing also for sustainability. If people really understand that the facilities are for them, and then they also need quality health care, that's the starting point. So I think that we need a wholesome approach to that before I get into the technical issues. But technically, if you look at sustainability, myself, I would really put sustainability into two, to say there's operational sustainability and also financial sustainability. If I talk of operational sustainability, I'm talking about those issues that I talked about that we had in this program, for example, trainings in operation and maintenance. We had trainings in sustainability, and we are working with the government of Zimbabwe at the forefront. So this ensures that even if the program ends, the government of Zimbabwe's workforce still remains in the areas, and they know the project inside out. They were the champions of implementing that project, so they will be there. And in this project also, if we talk of operational sustainability, we are also working with the healthcare committee that I talked about. So the healthcare committee is the people, the community that really own, in brackets, the healthcare facility. So those people, if they understand that is their healthcare facility, they will continue making sure that all the things that the project gains are guarded. And then we also had a lot of trainings. I'll give another example of the water point committee users. So we had water supply to these facilities. So the healthcare committee worked with us and the facility to then appoint what we call a water point committee that we trained also in the operation and maintenance. That's on operational sustainability. And I think we have, in a country, I should add that I think we have a very good technical expertise to really look at this. So a challenge can then be maybe the reaction time. If a tape, for example, is reported to be leaking at a healthcare facility, is the responsible department reacting in time before the problem becomes bigger? So it can start probably as a tape that is leaking, before then the whole latrine is labeled out of order, before the whole room is now closed, and it gets deeper to the pipes that then break down. And then when they now come to rectify the problem, they'll then say, we don't have adequate funds. But the problem started with a leaking tape that needed people to react as quick and as swift as possible to rectify that. So I think in terms of technical expertise, we are okay, but I think sometimes it's how we react, the reaction time and so forth on those issues. Then I'll go to the financial sustainability that I talked about. There have been a lot of discussions on the financial sustainability, but I think personally the viable way is adoption of those works that the partners to the government bring into the budgets of the local councils, be it Mutare Rural District Council, Harare City Council, such that if anything happens, they are the people who then go and make sure that those things are repaired and are sustained. I think in this project, we really did our level best, and we have moved quite a lot on that, because before that, we used to have people having the mindset of saying, after the project has ended, Madlamini, they then come and say, ACF, UNICEF, your latrine is now broken down after the project has ended, as if it's a UNICEF thing. But now the understanding, I think, is there. I was saying there's been a lot of discussions. Some are also favoring the issue of having user fees, to say if someone is coming to the facility, then they pay a certain amount, a minute amount that can be put aside for the operation, for the sustainability, if there is need for maintenance going forward. Some are also proposing the issue of having that facility having income generating activities at those facilities that can then have a side pocket for maintaining the things that would have come by the project. Thank you.
Thank you so much. It makes a lot of sense. And lastly, Livison, you had some vulnerable groups, in the community, particularly women and children. And can you give us some insight into how the upgrading of the healthcare facilities has improved for women and children in the communities?
Okay, that's a good question, Madlamini. First and foremost, I think when I was outlining the interventions that and the achievements of the project, I talked about on water supply. I talked about geysers that are now at the waiting mothers shelters.
Yes.
Yeah, that's a direct improvement to the mothers who come to get services. With this, I normally want to give an example of Odzi Clinic in Mutare. It's built on a hill. And because there was no running water, because the system had broken down, people the waiting mothers would then have to go down the hill to fetch water from the river.
By themselves?
Yes, by themselves, the waiting mothers. So you see now, that improvement is a huge improvement now if there is running water at that facility. And if you go there now, they have running water that they just, it's a tap away, opening the tap and closing the tap. And then they have the geysers. But if you look also at children, at Parenyatwa, for example, we rehabilitated a pediatric ward, A4, and if you go to Harare Hospital, we rehabilitated a neonatal ward. That's directly for children. But also, if you look at the whole project, the essence that we are coming in with the environmental cleanliness, IPC, if those children who come to the facility, they are protected in a way because they are not like us to say, okay, we are in a COVID era, we should not touch these surfaces, we should not. They run around.
Kids are kids.
Kids are kids, yes.
Yeah.
So if the environment is very clean, it means we have indirectly protected them, because kids are kids even if they are at the facility, whether they have come for treatment or if they've come with anyone else to the healthcare facilities. And for the mothers also, I had forgotten that even within the delivery rooms, We have, where there were no latrines within the delivery rooms, we've actually installed new latrines in those delivery rooms, and also everything that pertains to their hygiene and sanitation, like the hand washing basins and sluice sets. Sluice sets are within some of the healthcare facilities. We have also installed sluice sets. Thank you, Madam.
Wow, Livison, that's a lot of great work that you have done. Thank you so much, Livison Chipati. So, Wash, head of department, and he is also with ACF. Thank you so much for your time.
Thank you. Thank you, Zimbabwe. Over.
The program is Health Interventions. It was a Zim Papers radio broadcast simulcast. I am V Candy. We are back your way on Monday, brought to us by UNICEF.